Blood Horse Plus, available through bloodhorse.com, provides exclusive, timely, and unmatched content to subscribers, including Fox Sports, Blood Horse branded weekly programs, a detailed stakes winners section, behind-the-scenes videos from Blood Horse staff, on-demand access to deeper horse statistics, and a $5 monthly credit to equineline.com. Upgrade to Blood Horse Plus today.
Established in 1982, Rood and Riddle Equine Hospital is a worldwide leader in equine healthcare, providing a full menu of specialties of services and treatment for all breeds and disciplines of horses, from the family companion to the high-performance athlete. Learn more today about Rood and Riddle Equine Hospital. Visit roodandriddle.com or call 888-773-4838.
Hi, my name is Gary Falter with the Jockey Club. I'd like to welcome everyone to today's online panel. Now, this is the 6th panel in our series of 10 online Zoom panels this year. And today, this webinar, we're going to talk about and see firsthand a video of a surgery procedure of a tieback for a horse. And we've got Dr. Embertson, who is going to be with us all day, throughout this webinar. So before we get started, I'd like to recognize our sponsors, starting with the presenting sponsors, the Green Group and Bessemer Trust and Stoll Keenan Ogden. And our panel sponsor today is Rood and Riddle Equine Hospital, and our Q&A sponsor at the end of the webinar is West Point Thoroughbreds. And our thanks to all the sponsors for the continued support of thoroughbred ownership and helping us offer these webinars at no charge to you. So thank you very much, sponsors, for your support. So let's get started. I'd like to introduce our speaker, Dr. Rolf Embertson. Welcome, Dr. Embertson.
Well, glad to be here.
Okay, so you're a surgeon and a shareholder at Rood and Riddle Equine Hospital here in Lexington. And I believe you started there in 1986 and are one of the first partners at Rood and Riddle. Is that correct?
Yeah, that's correct. We did start in 86.
Great.
One of the few, yep.
All right. So if you have a question for Dr. Embertson, please use the Q&A button at the bottom of your Zoom screen. And you can submit a question, and at the end of the panel, we'll answer as many questions as time allows. So let's start off with a few questions for Dr. Embertson, and we're going to follow that with some slides, and then we've got the video of the throat surgery. So Doc, what are some of the throat issues that can affect a horse from reaching their athletic potential? I mean, could you just kind of give us a little bit of background on that?
Yeah, so I'm assuming today's we're going to talk about the thoroughbred racehorse. So
Yes.
the things that affect the thoroughbred, the more common things that we see in the upper airway would be a paralyzed left arytenoid. Some people would call that laryngeal hemiplegia. Probably the more proper term is recurrent laryngeal neuropathy. And that the reason for that is that it actually, that's the recurrent laryngeal nerve that is affected by it. So that's one of the more common things we see that probably affects maybe 5% of the thoroughbred racehorses. Dorsal displacement of the soft palate is another thing that can adversely affect the thoroughbred racehorse. maybe a little bit higher percentage than that in the thoroughbred horse. Is maybe 8 to 10% of those horses might encounter that at some point in time in their life. The say an entrapped epiglottis is another thing that can occur that obstructs some airflow, and we see that not very frequently, but we'll see it once in a while. Another problem that we run into occasionally in the racehorse is arytenoid chondritis, or inflammation of that arytenoid cartilage. So all those things can adversely affect performance.
Okay, and can most of these issues be corrected with either treatment or surgery, or some of those, there's just not a whole lot you can do?
Actually, most of the things I just talked about, we can help. We can improve airflow. Sometimes maybe corrected is not the right term for some of those. Like, for instance, a paralyzed arytenoid, you can't make them normal again, but you can improve that horse with surgery. The dorsal displacement of the soft palate, that shuts a horse down when that happens during a race. And there are some things we can do that, I don't know if it corrects it necessarily, but will prevent it from happening frequently. Entrapped epiglottis surgery essentially corrects that in most situations.
Okay, and do some of these conditions take place after the horse starts racing, or are most of these you can find them when the horse is very young?
Both.
Both, okay.
Like, for instance, the entrapped epiglottis, we see that in yearlings. You can see it in foals sometimes, although you're usually not scoping foals, but we see it in yearlings that are getting ready for the sale. And you also see it in a racehorse later. Interestingly, the paralysis of the left arytenoid is a progressive disease. And so we hardly ever see it in a young yearling. But as we're scoping those yearlings to get them, looking at them to see if they're going to be okay for the sale, you're going to start seeing a little bit of an increase in percentage that is affected by that. And that disease really doesn't come on very strong clinically usually until they're 2 or halfway through their 2-year-old year, sometimes 3. So, but in some situations, you can get an idea that that's going to happen as a yearling.
Okay.
So there are some things that develop and progress with time.
Okay. So before we watch the video of the surgery, you have some slides that we can review, and it helps explain many of these throat conditions, and especially as it relates to sale horses. So why don't we go ahead and go through some of these slides real quick?
Okay, so the first thing, what we do, we have a few slides here that are listed in the catalog. They're unacceptable. So if you see this in a sale horse, that horse does not pass conditions of sale. And that's why we scope the horses at the sale. So if you look hard, what's on your right-hand side is the horse's left side. It's like you're looking up their nose into their throat. And if you look close, you can see that the left arytenoid cartilage doesn't fully abduct as much as the right side does. Right there in the still image, you can see that. So it's not symmetrical and it's not quite synchronous. So some people would not pass that at a sale.
Okay.
Next slide. So this is the entrapped epiglottis that we talked about. Actually, the one on the left is a racehorse. The one on the right is a yearling. You can see the outline of the epiglottis there, but it's got tissue over it. So those horses oftentimes have a problem with airflow because it does obstruct some airflow. So usually we try to cut through that tissue and get it unentrapped.
So this could be corrected through surgery?
Yes.
Okay.
Yes. Rostral displacement of the palatopharyngeal arch. That's not a great term to use. That's what we used to see, or that's what we used to call it when they started making the conditions of the sale. But this actually is a congenital anomaly that is more properly termed laryngeal dysplasia. On the screen, on the video on your left, you can see there's a little bit of tissue hanging over the arytenoid cartilages, which are the two structures on each side that are pulling up and out of the airway. And that's the palatopharyngeal arch that is displacing. In the video on your right, you can see that the horse's left arytenoid is not fully abducting. Again, that is on the right-hand side of the screen. That's the left arytenoid. But that's not fully abducting. And most people would say, well, this horse is a roarer. He's got a paralyzed left arytenoid. But it's very important to look at the whole picture, and anymore on any of the horses that come into our clinic, we ultrasound the larynx also. And we can tell with the ultrasound if the muscles are becoming paralyzed or if the cartilages are abnormal. And so that's how you figure out some of these things. So that's another unacceptable condition. Next.
These unacceptable conditions, would they be rated like a grade 3 or 4 throat, or would this horse even be allowed in the sale?
That horse wouldn't make it to the sale. That horse, both those horses, those two images there, people would not have brought those to the sale.
Okay.
So a lot of these things get weeded out before the sale because they're scoped pre-sale to see if they're going to be okay in the sale.
Right. Okay.
But these two horses would not have made it. No.
Very good. Okay.
The next one. So permanent displacement of the soft palate, that hardly ever happens, and I don't have a good slide of that in here. But the other things I want to show here is the chondroma or inflammation of the arytenoid cartilages. So if you look on the lower left, that horse's right arytenoid cartilage does not pull up and out of the airway as well as the left. And when you see that in a thoroughbred horse, or actually any breed, it usually is not paralysis of that arytenoid cartilage. It's either the laryngodysplasia that we just talked about, so it's a congenital anomaly, or it could be a inflammation of that arytenoid and thickening of that arytenoid, which does not allow it to move all the way out of the airway. So if it's on the right side, it could be paralysis, but there's other things that it more likely is. If you look in the lower right, where you see the word chondroma in that image, if you look on the right arytenoid, there's a little whitish bump or cream colored bump that sticks into the airway, right about
right there.
Right there. So that would be considered a chondroma, where there's a little swollen area there that probably has a little bit of thickened cartilage. Sometimes those can develop into a bad inflammation within the arytenoid cartilage, and so most people would avoid that. Interestingly, that horse did go through the sale. The veterinarian didn't like what it looked like, but it went through the sale, and they said, all right, well, if it looks better in 90 days, then we'll still take the horse. But it still looked about like this, so they did not take the horse. The seller took the horse back, and she called me back, I don't know, earlier this year, and said that horse, nobody ever did any kind of surgery with it, and that horse won a couple races, so they were fine.
Okay.
The one in the upper right is more of a chondritis kind of a thing, or a granuloma. You can see that hanging off the left arytenoid there. That likely is going to grow and get bigger if you don't cut that off. So there's 3 examples of inflammation of the arytenoid cartilage, but all those are unacceptable at the time of the sale.
Okay.
And next slide. Subepiglottic cysts. You see that big egg-shaped thing kind of underneath the epiglottis in the top there. That is not acceptable, and that is something we can solve. We go in and take that out. Usually use a laser through the mouth to do that.
Okay.
And the bottom one is the cleft palate, and that actually a long time ago, some of those made it to the sale, but they don't anymore. But you can imagine those horses don't function well, and a lot of them with a cleft palate as a young horse get euthanized because they're aspirating and whatnot.
Okay.
So those are all unacceptable conditions.
Okay.
That's it. So the next couple slides, do you want me to go into this right now?
Sure. Yes.
So the next couple of slides here talk about the epiglottis. My partner, Scott Pierce, wrote a nice paper on this, looking at the different structures of the epiglottis. And these all that you see in this slide here, those three images, I would consider to be within normal limits for a yearling. But you can see the one on the left, the epiglottis, which is that tongue-shaped cartilage that's coming towards you right there. It looks firm. There's nice serrated edges. You can see the blood vessels on it. That is very normal looking for an adult or a yearling. The one in the middle, it does not look as stiff and structured as the one on the left. And that one I still would consider normal for a yearling. In a 3-year-old horse, you'd think that looks a little bit flaccid and you'd be concerned about it. And the one on the right, the same thing. You see the edges roll in a little bit. That cartilage looks a bit more flaccid or flimsy than the other two. And so some veterinarians at the sale would not pass that one on the right. And the reason for that is horses that have that kind of a structure are a little bit more likely to displace their palate when they're breathing hard.
Okay.
If we go to the next slide, you'll see a couple more examples of quite flaccid and smallish epiglottises. And actually, when Dr. Pierce went through and did the study looking at different epiglottic structure grades, and I think there's almost 3,000 horses that we looked at, and then looked at their race records. These horses with epiglottises that looked like in this slide here do not race as well as horses that have better looking epiglottises. The thing is, we don't know, was it because of the epiglottis or they get ankle chips or whatever, but we can say safely that in looking at the race records on those horses, that these horses do not race as well as the other ones. A lot of them don't make it there. And the reason is a lot of them will displace their palate.
So a horse with this condition, would they pass as far as the sale conditions?
Well, actually, yes.
Okay.
These two things would pass the sale catalog, but most veterinarians, this is one of those kind of deals where, pinhookers would absolutely not want these two horses, but they might develop into normal horses.
Okay. We hear that all the time.
Yep.
Okay. Very good.
Good on that. This is just a couple more examples of hypoplastic epiglottises. The top one is just narrow, and the bottom one is very flimsy looking, and the bottom one might displace his palate. Well, the top one just displaces palate. We oftentimes hold the horse's air off, by occluding the nostrils to have them breathe hard, and we try to see if they will displace their palate. Some yearlings can displace their palate, and it's within normal limits. But if it happens easily, that most people would shy away from that if it happens really easy with this very small epiglottis.
Okay.
So most people would just avoid purchasing this.
Sure. Okay. Got the last slide? We got one more?
These are just a couple more examples of subepiglottic cysts. Interesting, one in the bottom left. In yearlings or young horses with subepiglottic cysts oftentimes will have an entrapped epiglottis with it, which is the example on the lower left. And it actually has 2 cysts there, if you see it.
Right.
And the one on the right is just that's actually a 2-year-old, I believe, that had a cyst, but was not an entrapped epiglottis also. So that's
okay. And those can be lasered.
Yeah, we usually, some people try to do it through the nose. It's so much easier to go work through the mouth with the horse anesthetized and work with a laser and some instruments, and you can remove those cysts.
Okay, good.
That's
all right.
good.
That's any more slides?
Well,
so what?
Here's
let me.
There's a couple examples of entrapped epiglottis and what they look like when we got them unentrapped. So it's the same horse. Upper left is the same horse that's on the upper right after we did the surgery, and the same thing on the bottom. The lower left one the tissue entrapping the epiglottis is more thickened and inflamed. But once we got it off of there, that's what it normally looked like.
So the images on the right side are after the surgery?
Correct.
Okay. Yeah, they look fairly normal. Yeah. Okay. Good to see.
I don't know. Do you want to do some other questions first, or do you want me to get into the movement of the left arytenoid?
Yeah, you can get into it. Then I'll have a question here before
Yeah.
we get into the video of the surgery.
So the reason I put this in there, you know, I put the grade up there also. The arytenoid movements are graded 1, 2, 3, and 4. 1 being perfectly synchronous and symmetrical, 2 being asynchronous and asymmetrical, but still can maximally abduct when the horse is breathing hard. 3, they cannot fully abduct and maintain that abduction. So it drops into the airway, and 4 is completely immovable. It just sits there. So this is grade 3, you know, and we call it a B because it really doesn't move very far out of the airway at all. So the next image is an ultrasound of that horse. That right there is an ultrasound of that horse, and we can tell there's 2 images within that slide. The part on the left, it looks like there's a little bit more whitish tissue in the middle there. Right, come down a little bit. Yeah, so go up a little bit with your pointer in the middle there, and you can see, go up a little bit from there into the middle of that, up higher than that if you can. But you can see how much whiter that is than the image on your right in that area. So that's the normal side, that's the normal right side, and the other was the normal, or the abnormal left side. And we can see with the ultrasound that the muscles, which we're looking at here, become more dense. They lose, you know, water from within the myofibrils or the muscle cells themselves, and they become more scar tissue-like. And we can tell that with the ultrasound, which has really helped us out trying to figure out, you know, which one of these we need to do a tieback on. So this is a good example. This horse did have some movement of that arytenoid, but we know based on this ultrasound, this horse has progressive paralysis of that. It's helpful. All right, if you want to do some more questions, I guess.
Now let's just get through the slides.
Okay. So this is an arytenoid chondritis, or inflammation of the arytenoid. If you look at this slide, I think it'll play for you. The horse's right arytenoid, which again is on your left side, will move up and out of the airway, but the one on your right side, which is the left arytenoid, does not want to move very much. And actually, if you look at it critically, it's also a little bit thickened. So this is an example of a inflamed cartilage. This is not a paralysis problem right there. Yep. That's an inflamed cartilage, and that's the reason why it's not moving. It's thicker than normal, and there's inflammation around it. So again, you have to look critically at these when you're scoping the horse to figure out what exactly is going on.
So what percentage of young sale horses have scopes that are acceptable versus those that you would consider not acceptable? Is it a large percentage?
Well, I think, you know, the way it is now, that, you know, we talked about before, but most of the horses going to the sales have been looked at before the sale comes along. They have pre-sale evaluations. So the horses that get to the sales, I would say 95% of them are within normal limits. Maybe even higher than that. Now that doesn't mean that some veterinarians may not like what they see, but they are within normal limits when they're going there. So a lot of the other problems get weeded out before the sale.
So is there a standard that the veterinarians kind of go by as it relates to, you know, if you're scoping a horse, then another veterinarian scopes a horse? Or are you all looking at basically the same things, or does experience make a difference?
experience definitely makes a difference, and you will find different opinions from different veterinarians sometimes. We talked about that flaccid epiglottis. Some veterinarians absolutely do not like seeing that. Others are a little bit more generous. Again, if you're looking at it from the standpoint as if your client is trying to buy a horse that's going to race and not resell, then you're much more willing to take a chance on that horse.
Okay.
The same thing with the movement of the left arytenoid. That those two things are the conditions that there may be some disagreement amongst veterinarians looking at them of what they think should happen.
Okay, fair enough. Okay, so now let's go ahead and bring up the video. We're going to watch the tieback surgery, and we'll pause several times, giving you an opportunity to kind of talk about the procedure. And Doc, feel free to talk during the procedure to just kind of let us know what's taking place. So if we could start the video, and I think we've got it starting up now with the horse arriving at the clinic.
Yeah, we're walking the horse in the back door of the surgery area. And first thing we'll do is wash the mouth out. Hopefully she does that here.
Mm-hmm. Yeah.
Just we're going to put a endotracheal tube into the trachea, so we don't want to have food going down the trachea when we put that tube in.
So if the horse was eating hay or nibbling on straw, that flushes everything out.
Yeah, interestingly, we used to muzzle horses for 8-10 hours before their surgeries, and honestly, at our clinic, we hardly do that anymore.
Mm-hmm.
Part of it because we think that there's less problems with the gastrointestinal tract if they are eating normally most of the time. So we've gotten to the point we don't muzzle them pre-op very often anymore.
Okay.
So here we're just putting the endotracheal tube in because we'll use gas anesthesia to keep the horse anesthetized.
Okay. And a 1,000-pound horse, you're not going to have 6 big guys pick it up and put it on the table. So I always find this hoist interesting to see.
Yeah, and anyway, in equine veterinary medicine, you're going to have a hard time finding 6 big guys anyway. It's mostly women anymore.
Yeah.
But
All right.
we got a great team of technicians here. One of these is an anesthesia tech. The other ones are surgery techs. They know exactly what to do. And you're right, with a hoist, you don't need a lot of muscle on the people. You need some. You still got to position them on the table, but
right.
The hoist is huge. So.
Okay, we'll continue with the video. And the technicians, I guess, from a human perspective, are like nurses.
Yeah. Some of them are actually licensed technicians. Some of them have just learned the job here, and as we're working.
Okay.
And we've got, it's very important to have plenty of padding underneath these horses. Learned that a long time ago, so they're not tying up or having myositis problems post-operatively.
Okay.
Padding is very important, and positioning of the horse is important also. So again, this is going to be the tie back. So I'd like to have the horse's head positioned very close to the edge of that pad, which allows me to get at the surgery site better.
Okay, very well done. So this is a horse in training that's having the surgery?
Yes.
Okay, not a young horse.
Yeah,
it looks like
that was a racehorse. Yes.
Okay, so it looks like getting all the surgical equipment ready and sterilized.
Yeah, usually there's the surgeons at our hospital usually have an intern or a resident, sometimes both, working with us. They're trying to learn, just starting out in their career and trying to learn the craft.
Okay.
We have a lot of windows into our surgery suites. Some people like to watch, some people don't, but we're not hiding anything. If anybody wants to watch, see exactly what's going on.
So that was you just getting ready for the surgery, I assume?
Yeah, absolutely.
Okay.
Yeah. Prep our hands, surgical soap, and then get dressed. And the sterility is very, very important. You do not want, especially if you're putting a tieback suture in a permanent structure, you do
Mhm.
not want that getting infected. So
Okay.
stability is extremely important here. I mean, it's
So
true for
that,
surgery,
I
but
call these the surgical cloth. Feels like you got two layers of it,
yeah,
one
they're
on the
just,
horse.
yeah, they're paper drapes.
Okay.
Got holes in them, and then they're disposable. I think most people now use disposable rather than actual cloth drapes.
Okay. So it appears that you're just opening up the cloth to have
Yeah,
your targeted area.
exactly. So all I have exposed is the surgical site.
Okay.
The other thing that you can see, someone's fiddling around down on the left side. They're putting a scope into the airway, so I can visualize on the monitor the airway as I'm doing the surgery.
Okay. All right.
And you're going to also see I have a headlamp on because I work. You're working in a hole to do this.
Okay.
So you need a lot of light.
So are you watching the monitor as you do this and the surgical area? Is that what you're doing there?
Yeah, I mean, mostly I'm focused on the surgery site, but there's a couple things we're scoping them for. Is that, when we're putting sutures around the cartilage, we want to make sure we don't penetrate into the airway because the airway is contaminated.
Okay.
So we're watching to make sure that, we didn't inadvertently stick a needle through that mucosa into the airway. So
Okay.
that's the important part of where the scope is now. It's into the trachea. So we can make sure that nothing penetrates into the airway. And then we back the scope up, which you'll see later, and I can tell how much that when I tie down the sutures, how much that I can abduct or pull that arytenoid up and out of the airway.
Okay.
So this, we use retractors to get access to where we want to work.
So is that the metal thing you're holding on to? The
Exactly.
technician is that a retractor? Okay. So that kind of holds that open. So
Yes,
you've got an area to work in. Gotcha.
exactly.
Okay.
And then we'll put, usually most people use two sutures to do the tieback. There's varying techniques of how to do that.
I mean, just the term tie back, I mean, that really explains what you're doing. You are in the process of tying back one of those sides to open up that airway, if I assume correctly.
That's exactly right.
Yeah.
And perhaps we're not actually tying it back, we're tying it up and out.
Okay. Right.
But essentially what's happening is we're putting the suture along the same plane as the muscle that would, if it was working, would be contracting. So that muscle that is becoming paralyzed is called the cricoarytenoideus dorsalis muscle. That actually runs from the cricoid cartilage to the muscular process of the arytenoid, and we put the sutures along the same path as that muscle. And then when we tighten the sutures, it acts like that muscle in contraction.
Okay. And so what we're seeing here is the incision area that you're working in.
Correct. Yeah.
Okay.
So we work on, again, we're not in the airway doing this. We avoid going into the airways. We don't want any contamination of that site.
Okay. So we can see on the screen that airway is not being disrupted at all.
Exactly. You can see the endotracheal tube in there, but you don't see any sutures going into that.
Mm-hmm. Okay.
So right now it looks like I'm putting a suture through that.
Okay. So you're actually doing an internal suture.
Right. Exactly.
Okay. And I'll probably not use the right terminology, but you're suturing that flap on
Exactly.
the
Yeah.
left side.
Yes.
Okay. And we'll see that here in a moment, the results of that.
Yeah. So the muscular process of the arytenoid is what that muscle attaches to. And when the muscle contracts, it does pull that muscular process back. And so
Okay.
tie back makes the sense. The word makes a sense from that regard.
And it kind of helps that process or
Yeah.
yeah. Okay.
So now we've got the screen up. Now I'm watching the screen because I want to see if I have
Okay.
those sutures
So here we go. What are we
right
seeing
there.
here?
So you can see on that right there is it's actually called the left corniculate process of the arytenoid, but you can see it just got pulled up and out of the airway. And we try to pull it out of the airway to maybe about 70 to 80% what is maximum. Like
Okay.
normal horse that's breathing hard, they would be able to pull that arytenoid out farther than that, up and out of the airway farther than that. But we don't want to do that because, you know, those horses post-operatively would have problems with coughing and aspirating.
Okay.
So we pull it out to around 70, 75% of what's maximum. We know that over the next couple of days, we're probably going to lose a little bit of that. So,
Okay, let's pause for just a second on the video.
so
Okay,
you see
yeah, let's see it one more time. Go ahead, one more time. Okay, so there. Okay, so let's pause there. So it went back to where it was. So what took place there?
Well, what I did is I tightened the sutures. I just pulled the ends together without tying it yet. I wanted to see how well I can abduct that arytenoid with that suture. And
Okay,
obviously I could pull it to where I wanted it. I mean, you
and
just
you
saw
were happy with what you saw?
exactly.
Okay,
So now I haven't tied it tight yet. I actually am going to place another suture and make sure that one can do the same thing. And then I tie them both at about the same time.
okay, very good. Okay,
But that's what I wanted to see there is how much I could abduct that.
okay. And so just that little bit provides more airway for this horse to breathe, just that small amount.
Yeah, yeah. The one thing that's important to understand too is that when the arytenoid is paralyzed, when the horse is breathing hard, it doesn't just sit there; it gets sucked across midline.
Mm-hmm.
So it obstructs not only half of the airway, sometimes it'll obstruct, you know, maybe 70, 75% of the airflow. You can imagine when you're in a race, I mean, going down the stretch, that they slow down if they can't get enough.
Well, that's when you see it in a race, a horse, it seems like it hits a wall or something. It
Yeah.
just, it starts backpedaling.
Yep, they can't breathe. They don't get enough air, and so they have to slow down.
So now are you tying down those sutures? Is that what you're doing now?
Right now, I'm probably placing another suture.
Gotcha. Okay.
Yeah, it looks like I've got a needle holder there. So the other suture, what I've started doing over the last year or so, actually there's a little screw, a corkscrew with a hole in the top of it and suture that goes through that. And I've started using that in the muscular process of the arytenoid also. And so it's just a little different way of doing it. I put one suture actually through the cartilage, and then the other one I use that little corkscrew, and then I use titanium suture buttons on the back side behind the cricoid cartilage. So there's some metal in these horses now. Generally it gives you a more stable construct if you use that.
Okay.
And that's what you're looking for. You're trying to, every year it seems like we try to get just a little better at this, just a little better.
Sure.
And so I think our success rate has definitely improved over the last 10, 15, 20 years.
So what's this thicker string that I'm seeing here? All right. What am I?
So that's a drain. So when we separate the tissues in order to put the sutures in and around those cartilages, you separate a lot of nerves and vessels from the top of the larynx. And we don't suture that area back together because you're going to be running sutures through arteries and veins and nerves, which is not what you want to do. And so almost all of these get a seroma or fluid pocket above the larynx where we had just worked.
Okay.
And the thing that has helped me a lot over the last, I don't know, we've probably been doing this now for 7 or 8 years, is putting a suction drain in that site so I do not get all that fluid accumulation. It sucks it out. And I usually leave the suction drain in for a couple of days.
Okay, so that's a temporary thing. Okay.
That's a temporary thing. Yeah, not everybody uses that. In fact, I don't know anybody else that uses that, but that has helped me a lot in preventing seromas at the surgery site.
Okay, very good. So now are you starting to suture the incision?
I think I was suturing the drain in there, but
the drain.
As soon as I get the drain secured, then we suture the incision. So I'm probably now starting to suture the incision. Yeah.
Okay.
And usually we close it in 3 layers. But essentially it's deeper fascia, subcutaneous tissue, and then skin. We don't close way deep in there because of all the stuff you might hit that you wouldn't want.
There's things in there. So this video we've been about 10 minutes into it. How long was the actual surgery?
It take from skin to skin, it'll take me about 45 to 50 minutes.
Okay. All right. It looks like you're just about wrapping up here.
Yeah. Yeah. So we put this suction device on that little tube that you saw. You can see that little plastic thing in her left hand. It's just a thing you squeeze, and then it's got suction in it. Then we usually put just a Coverderm Band-Aid kind of over the incision for recovery.
Okay.
And then oftentimes that comes off after we're done with the recovery.
Okay. Well, when I first watched the video, I was wondering at the end, okay, well, what is that tube and that little bulb at the end? So
yeah,
thanks for the explanation. So that helps with the drainage. It's
just a suction drain. Yep. And I think probably not very many people use that, but again, it's helped me out on these things.
Okay. So for this horse, how long for a recovery before the horse can go back in training? I mean, is there stall rest, hand walking? What's the routine for this horse?
Yeah, so usually the horse stays in the hospital for 2 to 3 days, and the reason for that is that I go in the next day with the scope and using the laser to remove the left vocal fold, and we just do that standing with the horse sedated. And then sometimes the incision either in the throat that I do with the laser or externally here will swell a little bit. So I like to watch that to make sure we're doing fine before we send the horse back.
Okay.
To the farm. And then they usually goes to the farm. It's 2 weeks in a stall rest, and 2 weeks stall rest in hand walking, or 3 weeks stall rest in hand walking. But usually by 4 or 5 weeks post-op, they can start back in training.
Okay, very good. And so this horse is then going into recovery and will stay at the hospital for a day or so?
Yeah, a couple days, yes.
A couple days, and then go back to the farm or to wherever the horse resides. Okay, great. Well, a fascinating surgery. I just really appreciate your taking the time to do that. So what's the success rate on the tieback surgery? Does it work all the time?
No, it doesn't work all the time. It'd be nice. Nothing's 100% no horse, but I think that now, again, for people who do a fair number of tiebacks, probably 60 to 70% of the thoroughbred racehorses get back to a level near where they were before they had the problem. You cannot make them normal. You can't make them normal. Again, there's even if we end up with a retinoid positioned at about 60% of maximum, that's going to improve their airflow significantly. And so a lot of those horses can get back to the track and run well. I mean, if they were a graded stakes horse, some of those horses can get back in graded stakes company, but that means that 30 to 40% of the horses don't, right? And that's actually a large percentage. So the most common reason why they are not successful, that 30 to 40%, is because the sutures kind of settle into and cut into the cartilage a little bit, and then that tie bag loosens. That cartilage gets dropped back into the airway a little bit, obstructing more airflow.
Okay.
That's one of the reasons. Another one is some horses will cough a fair amount after the surgery. Again, that has to do with experience of the surgeon, I think, and also how far you've pulled the arytenoid up and out of the airway. So some of those horses end up being failures also.
Okay. Can you go back in a second time? I mean, is that ever advised?
Yes. Yeah. If they fail, that's what I would advise to do, is to go back in a second time if the horse has some talent and is worth doing.
Okay.
Other people actually have removed the arytenoid, but that is not as good a result as doing a second tieback.
Okay.
Problem with the second tieback is they're difficult to do because you have a lot of scar tissue in that area to work through, and that makes it a hard surgery. So.
Okay. Well, why don't we take a short break here, and we're going to go into the Q&A session with the audience. We have some questions in the queue from the audience. So while we sort through those questions, let's just hear from our Q&A sponsor, West Point Thoroughbred. So stay tuned. We'll be right back.
How do you become the gold standard in racing partnerships? One horse, one partner, one victory at a time. Congratulations to all our partners who have made West Point the gold standard for the last 3 decades.
Okay, we're back. So first question from the audience, are these hereditary conditions?
They can be. It's not black and white, a direct kind of a situation, but taller horses tend to have this problem more. And there may be some other heritable factors there, but in general, we don't really consider it to be strongly hereditary from a genetic standpoint, or we'd stop breeding those horses to try to prevent it. And there's a lot of really good stallions that also have genes to run fast. And they might throw some of these every once in a while. Some of the offspring might have this problem. So there is some heritability to it, but it's not a direct relationship. And
so let me add to that. If I'm going to the sale to buy a broodmare prospect, would you recommend having her scoped to see, and say she was unraced or lightly raced? Is that something you'd be concerned about?
That's interesting. I don't think very many people scope broodmares at the sale.
Okay.
And honestly, I would say that even if you saw one that had a paralyzed arytenoid, that wouldn't stop me from buying that mare, because the odds of her throwing another one are not very high.
Okay.
If she was a good horse. So,
okay.
And again, I mean, for instance, like draft horses, we probably see this problem in maybe 35% of the draft horses. And whereas in thoroughbreds, you might see it in 5 to 6% of the population, and we don't see it hardly at all in quarter horses.
Oh, okay. Interesting. Okay, next question. How many of these conditions appear normal when standing, but would show on a video during training?
Dorsal displacement of the soft palate, you almost have to scope them during exercise to see that happen. That's not always true, but oftentimes it is. For the tieback, usually by the time that we get him in the hospital, there is less movement of that left arytenoid, and they're already starting to make an upper airway noise. The trainers can kind of tell that, and the other thing which I should mention is that, again, this is a progressive disease, and so if 80% of that cricoarytenoideus dorsalis muscle that pulls the arytenoid up and out of the airway is still working, you might be fine in a race. But if now you're down to 65-70% of it working, you might be able to get to 6 furlongs just fine, but then that muscle's done. It's fatigued. And so now it gives up, and the arytenoid comes across the airway, and they stop.
Yeah, I remember a guy telling me about a champion sprinter that if it could breathe, would have been a horse that could go the mile and a quarter, but just didn't have but ended up being a champion sprinter.
Yeah, no, and that's true. If you and with this problem, you probably do want to run them a little shorter after you do the
Okay.
time.
Okay. Good to know. What treatment or surgery can be done to help horses that displace their soft palate during exercise or racing? So, what kind of treatment or surgery for those horses?
Well, a lot of times the trainers are already putting a figure eight nose band on to try to decrease them from opening their mouth as much and breathing anything or having the air go in through their mouth. Since they're obligate nasal breathers, they're not efficient if they're breathing with a displaced palate where some of the air is coming through their mouth.
Okay.
Tongue tie, and what that does is actually the back of the tongue attaches through what's called the hyoid apparatus, which also is connected to the larynx. And so you're actually pulling the larynx forward a little bit when you pull the tongue forward and tie it down, which then should jam the epiglottis a little bit more into the soft palate, so they're a little less likely to displace. Now, that doesn't always work, but I would
Okay.
suggest you see a lot of tongue ties on horses when you go to the track.
Well, I always thought they tie their tongue so they don't get the tongue over the bit.
Well, the one thing about it, if the tongue goes backwards at all in the mouth too, that pushes on the larynx a little bit and may push the epiglottis up a little bit and have it more likely displace. So,
Okay. Well, that's something I didn't know. So do you generally only tie back on one side during the surgery?
the answer is yes, because usually it's only one side that's involved. And it's almost always the left side. So again, the left recurrent laryngeal nerve is the longest nerve in the horse's body, comes out of the brainstem, goes down the neck with the vagus nerve, and then separates and goes actually around the arch of the aorta on the left side and back up the neck to innervate the larynx. We think that the stretching of that nerve was what causes the damage to that nerve. And so the right side is not as long and doesn't have exactly the same course as the left side. So it's almost always a left-sided paralysis. And so that's what you're doing is the left side.
Okay. Question, is there any research or new approaches to fix this problem? And I'm assuming they're referencing the tieback.
Well, yeah, and we talked about that a little bit in that surgery. And for a long time, most everybody was putting a couple sutures around and up through the cricoid cartilage, then bringing it forward and putting it through the muscular process, the arytenoid, and tying it. And there's certain areas the cartilage is a little bit thicker than others and should hold suture a little bit better. And everybody learns that as you go. Well, more recently, have been using titanium buttons on the back side of the cricoid because the button that you're putting the suture through doesn't tear through the cartilage. And so it's a more stable construct in the back of the cartilage there. And then I mentioned that screw that we used, that tends to not pull out as much as sutures might cut into the cartilage. And there's, again, the research that has been done on those would show that statistically they did make a difference. Now, not everybody uses them because they're comfortable doing it the way they like doing it, but yeah, we've made some progress. So.
Okay. So it's been said that throats can be rated as okay to race, but not okay for pinhookers, which seems contradictory. How can it be the results for young horse scope can have two very different outcomes? Okay to race, but not okay to pinhook.
Yeah, well, we mentioned that a little bit earlier. The ones that people don't want to pinhook are the ones that have a little bit more of a chance of having a problem. So if you already see that the left arytenoid is getting a little bit slow to fully abduct or doesn't quite fully abduct, pinhookers, again, are not going to touch that, whereas you might be just fine buying that as a racehorse if you got it for the right price. So, and the same thing with the epiglottis, some of the Epiglottises that look flaccid, they might be just fine, but
Okay.
a lot of pinhookers don't want to take that chance.
Okay. And the follow-up to that is in the CBA booklet on scoping, they reference rating the throat of grade 1, 2, 3, and 4. Are these gradings accurate? Is that what most veterinarians go on, grade 1 through 4?
Yeah, you got to be a little careful. There are some different grading systems, but what that refers to, the grade 1, 2, 3, and 4, is only regarding arytenoid movement. It's got nothing to do with how flaccid the epiglottis is. Doesn't, if they displace their palate, yearlings are more likely to displace their palate than an adult horse does. Partly because of the inflammation in the upper airway. But that grading system, 1, 2, 3, 4, pertains only to movement of that arytenoid. And we actually break it down into subcategories to describe it a little better. Like if I was on the phone with you and you've scoped an awful lot of horses, I said, well, this horse actually has a 2B left arytenoid, you'll know exactly what that is. That means, he had to struggle just a little bit to get it to fully abduct, but yet he did. So he passes conditions of sale, but he had this, he had to hold his air off for a while to get it there. Okay. Whereas, if I said he had a 2A, that means he's not as synchronous and symmetrical. He's not perfect, but he easily fully abducts and they're normal. And in fact, if you go through in that paper that Pierce wrote, probably 65% of the horses are 2As. They're not 1s.
Okay.
So the majority of thoroughbreds actually are not perfectly symmetrical and synchronous.
So a 2A versus a 1A. 1A would be...
There's no A or B. A 1 is perfectly symmetrical and synchronous.
Okay.
The 2 is then an A and B.
Okay.
But the 1 is just, they're just fine. So,
okay.
And
So
it's important to know that, 1s as yearlings can become paralyzed as 2-year-olds.
Oh, they can. Okay.
Yeah. Just because you bought a 1 throat as a yearling doesn't mean that disease doesn't occur yet. It just hadn't hit them yet.
I see. Okay. Good to know. A couple more questions here. Does the paralysis have to be 100% to do the surgery?
That is an old wives' tale. A lot of people used to believe that because if there was still movement of the arytenoid, they thought, well, it's going to loosen the suture. Well, we've actually wrote a paper out of our practice, looked at about 600 thoroughbreds and proved that grade 3s, before you did the surgery, where there's some movement still, did just as good, if not better, than ones that were completely paralyzed or grade 4s.
Okay.
And so we do not wait anymore. If it's adversely affecting the horse, even though that arytenoid has a fair amount of movement, we recommend doing the surgery.
Okay. So last question. When a horse has a nasal strip across the bridge of their nose, what exactly does the nasal strip do, if anything, to help a horse breathe? Do we have a slide for that, maybe?
Yeah, I think there's a couple slides there. So this became really an issue, with California Chrome back in the Belmont. But they started back in '99, and the thought was that it does improve airflow in the front part of the nasal passages. And there's actually some research Dr. Holcomb did at Michigan State that would suggest that that is true, that there is less resistance to airflow if they are wearing that nasal strip. The other thing that they showed, actually probably the next slide you could put up then. Dr. Valdez at University of California back in 2004 also showed that it may have decreased pulmonary bleeding if they have a nasal strip on. And the reason for that is that, if there's any obstructions in the upper airway, the negative pressure within the airway to get air down to the lungs gets worse. And so that may have contributed a little bit to the bleeding if there is some obstruction in the upper airway.
Okay.
So there's some validity to it, I think, but not every horse needs them. You're not going to, step a horse up that's already a really good horse sometimes, but it's interesting. That picture I showed you is at the 3-day event here in Lexington, and I would say probably 75% of those horses are wearing nasal strips.
Is that right? Okay,
Yeah.
interesting. Here's another question that just came in at the last minute. What are the drawbacks to doing the tie back surgery? Are there any long-term issues experienced because of that surgery as a result of it?
Yes. Generally not, but yes. The biggest long-term problem that we sometimes see is if the horse is coughing, and they cough because they get a little bit of food or water in their trachea. Just like if we get it down the wrong pipe, we'll cough too. And that irritates the lining of the larynx and trachea. And that can go on for a long period of time. Generally, it's not a huge problem for the horse, but some horses will aspirate enough, they'll get pneumonia from that. And
Okay.
so that can be a problem. We don't like to see that happen, but some of them do cough for a while.
Okay. All right. Well, Dr. Embertson, that wraps up our Q&A. And I'd like to tell the audience, if you have a follow-up question for Dr. Embertson, send it to me and I'll forward it on. And really like to thank you, Doctor, for your time, for your insights, and just helping us better understand, what goes on with this tie back throat surgery and what it's all about. So really do appreciate your taking the time to video the surgery and to explain everything to us today.
Well, thanks for having me, and I hope somebody got something out of this. So,
I'm sure we did. So also like to thank our audience for being here and to all owners who invest in our sport, because without owners, we simply just don't have an industry. So thank you very much, audience, owners, for watching. We'll be back in September with another online webinar. So until then, we wish you well. Have a safe and enjoyable August, and we hope you visit the Winner's Circle and you visit it often. Well, thank you, Doctor. Thank you,
thank you.
everyone.
Take care.
Mhm.